So yes, welcome back everyone. And I did want to just repeat that anyone who is, if you're worried about your grade or any of your assignments, please shoot me an email. I think I tried to get in touch with everybody and reach out to all of you if you're having a hard time. If I didn't manage to get a hold of you, or if you didn't get an email from me, check your emails and know that you can email me and let me know what's going on. I have my office hours today from 6 to 7 and on Thursday from 4 to 5. So if you can and you want to show up for those office hours, I can certainly go through your grade and how things are looking. What I do want to do is to first of all acknowledge, the hard time that many students have had. This has been a really rough semester, and people are trying to work and manage families and school and health issues. So I want to say well done for all of you for just hanging in there and keep going. And this may not be your best semester at Cal State, but know that you are persevering, and we want to finish strong. We want to make it through the end of the semester. And I want to make sure that I help all of you who have had a hard time. So what I would like to propose to you all is, especially anyone who's not done as well as they wanted to or had a hard time, what I wanted to propose to you was that anyone who still has any outstanding homework, even if it's homework from the beginning of the semester, shoot me an email and let me know if you want to turn that in. Even if it's late, it doesn't matter. Let me know if there is anything that you need some help with towards the end of the semester. I want to make sure that you've all had an opportunity to turn in your observation write-up. If you didn't come to the observation, it's recorded. You can still watch it. You just have to answer a few questions. Definitely worth doing to get those points if you haven't done that already. And I want to also let you know, don't worry about late points. I'm not going to take any points off for anything being late. Just try and get it in. Homework number 8, that was due yesterday. Again, if you haven't done it, don't worry. Just try and get it in before the end of the semester. And then we've got 2 more homeworks left. Homework number 9, which will be based on today's lecture, which is about swallowing disorders. I haven't posted that yet because I'm going to see how much we get done today and how much I'm going to give you to work on for the rest of the week. And then we'll have our final one, which is about audiology. You're also going to have an opportunity for some extra credit at the end of next week. In my office hour next Thursday, I've got the ASL interpreter coming to chat to you, and I would love to have her come to class, but we just don't have enough time. So I've invited her to come to the office hour, and again, I'll record that, but just to have an opportunity for lots of you who I know have taken sign language classes, maybe to figure out, what do I do with that? What kind of options do I have if I've taken sign language? How do I, turn that into a job maybe? Or how do I have a little side hustle with my ASL? So if you can, come to that and you can meet with her. And if you can't make it, I will record it. And then anyone who asks a question or makes a comment, I'll give you extra credit for that. So that we can try, and I don't want anyone to fail this class. I don't want you to have that on your plate as well as everything else. So I want to do what I can to make sure that you can, make sure you pass the class. If you are struggling and you can always take the class again, right? So if you feel like I just got to get through this and then I can retake it to get the material, you can do that. So we'll just try and figure it out together. Okay, so swallowing, I think that's where we're going to start. Before I dive into that, does anyone have any questions or comments about anything? No, we're all good. You probably all did lots of swallowing, hopefully with some good Thanksgiving food. Mary, did you have a question?
I did, but honestly, it was kind of just I don't know if it's a good question, honestly, but it was it just kind of popped in my head when I was watching the videos. but you know how congenital comes from birth? Um, if it's something that happens like during your birth, is it still considered congenital or acquired? Like, you know how you said anoxia happens like during birth sometimes? Does that consider that you know, at your birth or congenital? I don't know what that would be labeled as.
That's a really good question, Mary. I might have to ponder that one, because that's a little tricky, isn't it? Because on the one hand, if this is a child who prior to birth was a typically developing child and then they had complications during birth, would we say that that is congenital because it was present at birth, or acquired because prior to being born they were typical? Mary, I don't think anyone has posed that question before. Or maybe they haven't, I forgot the answer to it. I may have to ponder that one and get back to you, because I think there could be a case for both sides, right? Because you're right, in the definition that we use of congenital present at birth, it is present at birth, but it's kind of acquired too. If it was through kind of a traumatic birth and hypoxia, a lack of oxygen. Okay, I'm going to have to find someone smarter than me to answer that question. And then I will post, maybe I'll post a comment, or I'll let you know next week.
Okay, I just assumed that there was going to be like another fancy word that you had in your list that kind of like corresponds to that exact scenario.
I'm all out fancy words. Yeah, no. But it's a really, really good question. I love that you are really trying to tease apart, like, what really is that difference? What does it really mean if it is congenital versus acquired? Because you can have something acquired at birth. Okay. Who's the smartest professor in the department I can ask? I'll find that. All right, I'm just write myself a little note. All right, to be continued. Thank you. All right, so let us dive into perhaps our swallowing today. All right, let me just get ready. Oops. All right, here we go. Okay, so I do have a fancy term for you there, Mary, and that is dysphagia. And that is the fancy word for a swallowing disorder. Some people may say dysphagia, some people say dysphagia. What I would like you to be sure of, though, that you spell it with a G, because it relates to swallowing. And if you spell it with an A, it may sound like it is dysphagia, like aphasia. So we want to make sure that we do differentiate aphasia, which is a language impairment, from dysphagia, which is a swallowing impairment. Now, typically, if we were in person, I give you things to eat and drink when we do this, but I can't, so you'll have to manage for whatever snacks you have on your table and drinks that you have with you. But what I would just invite you to do momentarily is to think about, you know, when we're talking about swallowing, it's something that we absolutely take for granted. We don't think about it until we have a problem with it. And I guess that could be true for speech and language, right? We take that for granted as well. But I think what we don't necessarily think about is in non-COVID times. I mean, this year has been very different for all of us, but in non-COVID times, think about what Thanksgiving means. It means getting together with your family, with your friends, sharing food. And for somebody who's got a swallowing difficulty, it absolutely changes how we relate to people. The social side of swallowing is huge. I mean, how often, again, in non-COVID times, do you go out for a drink with somebody? You meet up for lunch, you go have coffee together. And when you have a change in your swallowing, it can make people not only physically find that they can get things like a pneumonia, they can get a lot of weight loss because they are not able to eat and swallow properly. It also cuts out so many of the social things that we do. So it's a big problem. And in the hospitals, if you decide that you want to perhaps pursue a medical speech language pathology path, in the acute part of the hospital, meaning when somebody has just had a brain injury, just had a stroke, the majority of your assessment and treatment is dysphagia. So for the therapists who work in the one of the hospitals that I work in, I would say 80 to 90% of what they do is swallowing disorders. And as you get further away from the acute care, like in an inpatient rehab, it's probably about 40%. In outpatient, I work in inpatient and outpatient. In outpatient, it's more like probably 10 to 20% of your caseload. So just know that this can be a field in and of itself, and we have people who are specialized in dysphagia as well. Okay, so let's maybe start off with a bit of a definition about what it is. So what I really want you to try and think about is, you know, we have this system that we use to breathe, and we've talked about the ventilatory system. We've talked about, you know, how we breathe in and out, and we've talked about the throat and the pharynx for voicing. But think about this system that we use to breathe in is also partially shared for swallowing. And so this is where we run into problems, is because physically they're very close together. So when we look at what swallowing is, it really is the process of getting solids and liquids from your mouth to the digestive system, bypassing the respiratory system, meaning that our goal with eating and swallowing is to get food and liquid from our mouth into our stomach and to not go into our lungs. That's really what it is. And so we have to shift from one system to another to make sure that we don't inhale food and liquid. It's a really complex coordination of muscles and nerves when we swallow. And, you know, again, we don't really think about this until we have a problem. So we've got 30 pairs of muscles in the head and neck, 6 pairs of cranial nerves, and then we have this complex system that is involved in the brainstem and other areas of the brain. So when somebody, for example, has a stroke in their brainstem, or they have a stroke in another part of their brain, it can affect their swallowing. We can also further define dysphagia as difficulties with either sucking, chewing, and or swallowing. So think about sucking includes babies, right? When babies are first eating, you know, when they're drinking and when they're getting milk, if they have difficulty sucking and nursing from their mother, then that is classified as pediatric swallowing disorder. It is also difficulty moving the food from the mouth to the stomach, and it can occur when there is a problem in any of the pathways listed above. So those pathways, the pairs of muscles that we just talked about, the cranial nerves that we just talked about, and those areas in the brain that are essential for organizing our swallow. Anyone can have a swallowing disorder in terms of age. It can be from birth, and it can be all the way up until you get older, and anywhere in between. And we'll talk later on today, hopefully, a little bit about the types of people who have difficulties with swallowing. Can occur from acquired or congenital or developmental disorders. So again, across the lifespan, it can occur, and for different reasons. Okay, so the way that we are going to look at it is we're going to talk about swallowing in terms of stages or phases of swallowing, just so that it makes it a little bit easier for us, I think, to understand each part of the swallow. So we're going to talk about these 4 different phases or stages, which is the oral preparatory phase, the oral phase, the pharyngeal phase, and the esophageal phase. Now, when we're talking about people who are healthy, that's hopefully us, is that as we chew our food and swallow it, the food and liquid goes just through these phases in a seamless way. It doesn't kind of stop from one phase to the other. We don't even know that it's going through these phases. So know that the way that we are breaking it up is a little bit artificial, but it's so that we can really understand each phase of it. And typically we would just see all of these together. Okay, so let's start off by talking about this oral preparatory phase. So I've got a little diagram for you here so that we are looking at a side view of the head so that we can see which parts of the body we are talking about. And when we're talking about the oral preparatory phase, think about it as preparing. What do we do to prepare? Well, the first point here says it's manipulation and or mastication of the food. And mastication is just the fancy word for chewing, right? So it is your ability to prepare the food. So when we think about the anatomy that we need, if you have a bite of something in your mouth, what anatomical structures are you using? Well, you're using your lips, because your lips are what help you to get the food off the spoon or the fork, and your lips help you to keep it in your mouth. The tongue is really important, right? So down here I've got rotary and lateral movement of the tongue and the mandible. So the tongue is very important because we have to be able to push that food from side to side under our molars for chewing. And then that tongue is what is going to help us move the food around as well. We have our teeth. Obviously, our teeth are important in biting and being able to bite and chew and mash the food up. Your cheeks are important. Now, you may not realize that your cheeks are important when you chew, but your cheeks help you. You have tone in your face. And when you're chewing, your cheeks help you to keep the food in the middle of your mouth. And what we do find, all of us, I'm sure, is when we eat, you find that sometimes food gets stuck down the side and you have to, use your tongue to get something that's fallen down. Think about somebody who's had a stroke and they may have a paresis or paralysis on one side of their face. What we frequently see is they get a load of food that gets stuck down one side because their tongue isn't working very well. They've lost the tone in their cheek. And so we frequently have to look in there and check and have them learn how to make sure that they check that they don't have a bunch of food. If you've got weakness in the tongue, the cheek, food can fall down in between your cheek and your gums and your teeth. The alveolar ridge is important. Now remember our alveolar ridge in that little diagram up here, it's that bumpy part right behind your teeth, because as you're chewing, your tongue pushes up there to help keep the food central in your mouth. Hard palate, remember your hard palate, that's the bony part, that's important as well. Again, we've got this container for the food. So as we're moving it around, the tongue moves it side to side, and we've got hard palate on the top that keeps it all in the middle. Soft palate is also important. Think about your soft palate here while you are chewing. Your soft palate is hanging down, and that's again just to try and help keep all of your food contained in the oral cavity. Mandible, that's your jaw. Think about your lower jaw, that's really important in chewing. And your salivary glands. Think about your saliva as being the first part of the digestion process. We have enzymes that are in our saliva that help to begin the breaking down of the food already in your mouth. It starts to get broken down with the enzymes in your saliva. So just to review some of these points, because I got a little ahead of myself. When we chew up food, we create what we call, technically, when we're talking about swallowing, we create a bolus. So a bolus is really just, it is a lump of chewed up food. So when we are doing a swallowing test, we talk about a bolus, and we are really talking about a quantity of food or liquid. And it just means the food or liquid in your mouth that you are going to swallow. So we'll talk about this again if we have time today to talk a little bit about evaluation of swallowing. We might talk about giving somebody a small bolus, meaning just a small amount of food or liquid. Or we can say, a 5 milliliter bolus, so we can really measure how big it is. So bolus then refers to either food or liquid that is in your mouth that you are going to swallow. We talked about the labial seal. Again, your lip seal is important to make sure that food doesn't fall out the front of your mouth. It helps contain it in your mouth, in your oral cavity. I've had somebody before, not just somebody, but multiple people who have a really difficult time, maybe after a stroke or if they have a neurological disorder, keeping their lips closed. And what happens is food and liquid just pours out the front of their mouth. So lips, very important. We talked about the muscle tone, and then we talked about this rotary and lateral movement of the tongue and mandible. So think about when you chew something. This is the point in the class when I give you all typically some gum. So if you have gum, pop a piece of gum in. But when you think about when you chew gum and you think there's that that rotary movement is like that rounded movement that we do, and lateral is side to side, because as we're chewing something, we are moving it with your tongue and with your jaw's going up and down and round, and it's really to make sure that the food gets really well chewed up, well masticated. And then we just talked about our saliva then. Okay. Oh, and there's a little point there. Oh, sorry, I didn't realize we got one that was, oh, hanging off the bottom there. It says larynx and pharynx are at rest. I apologize, it fell off the bottom of my slide there. So what that means is, while you're doing your chewing, think your larynx is not really doing anything and your throat is not doing anything. All of the work is just going on in the oral cavity. Okay, now let's talk about the oral phase. So remember, phase number 1 is the oral prep phase. We are preparing the food. Now, if you're taking a sip of liquid like this, there really is no oral prep phase, right? I don't have to prepare my sip of water. Once it's in my mouth, I'm just going to go straight to my oral phase. So just to back up slightly, I think oral prep phase is really important for solid foods. And think about, the more solid or the more challenging the food is, the longer the oral prep phase. If you have something like yogurt or something that doesn't require a whole lot of chewing, your oral prep phase is going to be very small, right? You don't have to chew yogurt, you don't have to chew anything that is already mushy. But if you were to eat some beef jerky, you might have a prolonged oral prep phase, because you really have to chew it up very, very well. Okay, so now the oral phase is, okay, once the food is ready, you know, what happens to it? What are we going to do? So the food should be ready and swallowable. It is crazy. Your brain does so much without you knowing it. As soon as you take a mouthful of something, we have all of these sensory receptors. This is a side note, so you don't necessarily have to write all this down. I'm not testing you on this, but just so you know how things work. All these sensory receptors in your oral cavity and in your pharynx are sending information to your brain about the texture of the food, the quantity of the food, so that you automatically know how much to chew it, how hard to swallow, just based on the temperature, the texture, the size of the bolus that you have. So our bodies know that, yes, if we have something that is very big in there and something that is very chewy in there, our brain sends the message to chew a whole lot more. So you can imagine then, when people have a brain injury or something that has occurred to affect how they are perceiving what is in their mouth, it can be quite dangerous if somebody doesn't chew adequately, if they take too big of a bite, if they don't take the time and they are shoveling food in there. So our brain recognizes all of these things so that we know how much pressure to exert when we swallow. We know how much we can swallow. So we have this sensory information, which is temperature, touch, and pressure, that comes from the tongue and the palate. Again, that helps us to know how much force is needed to basically push that food back. It begins with the posterior movement of the food or liquid. So we've done our oral prep, we've chewed up this food, and now our oral phase is going to be as we push that food backward. And we have this quick, forceful, wave-like action of the tongue. We sometimes call it the stripping action. And so this stripping action, or this wave-like motion of the tongue, is how we push our food up and back. It's how we get it to the back of our mouth so it's ready to be pushed further down and swallowed. This active containment of the bolus that we really need. So while we are doing this, while we are sending this food back, we have to have a good lip seal still. We have to have our cheeks that are still keeping the food in the middle. We have to have our tongue that is helping to keep that food in the middle. And then even our soft palate, because when you start to push that food back in your mouth, your soft palate, if I just quickly pop back here, when you start this oral phase, your soft palate is going to move up and is going to block off your nasal cavity. That's to make sure that when you swallow, food and liquid doesn't come out of your nose. So during that oral phase of pushing that food from front to back, the soft palate is going to move up and meet the posterior pharyngeal wall so that it doesn't come out of your nose. And you know that if you have ever had a mouthful of something and somebody makes you laugh and it squirts out of your nose, it's because that pressure has pushed it past your soft palate. Um, the lateral edges, meaning the sides of your tongue and the tip of your tongue, as you swallow, go up against your alveolar ridge. And that's so that it helps to push the food up and back. How long does this take? Well, it takes between a second and a second and a half from the point at which you start to push that food back. It's very quick. So you've done all your chewing, and now it's the point at which you get ready to push it back. That takes just about a second to push that food back. Okay, I'm going to go through all the stages and then we'll watch some videos so that we can see what it all looks like. Third stage, the pharyngeal stage. So what is happening in this pharyngeal stage? So remember, pharynx is your throat. So this is the stage, this is a very important stage, and probably one of the reasons why it's the most important stage is because this is when a swallow is triggered. It is in this pharyngeal stage. So what typically happens is we've pushed that food back, and there's a point at which we are going to have this, this series of motor movements that are going to cause us to swallow. So what I mean by that is we have this sensory stimulation to the oropharyngeal area. Now, when you think about oro refers to the oral cavity and pharyngeal refers to the pharynx. So if you think about in your mouth, right at the back of your mouth, somewhere in there, your swallow will be triggered by your tongue pushing the food back. So we have sensory receptors taking information to the brain that says, oh, that food is ready to be swallowed. Now, it is not one particular area, but I would say if we look in the mouth, if you look in your mouth, you have these arches at the back of your mouth, and usually it's somewhere around those arches. They are called the facial arches. That our swallowing is triggered. But in general, just know that it is somewhere in that oropharyngeal region, meaning right kind of at the back, the posterior part of the mouth. And as that tongue moves back. Now, what happens? Well, we have this cascade of swallow events that occurs, meaning that it's one thing after the next that occurs. And rather than it being a true reflex, sometimes we talk about a swallow reflex. It's not really a reflex. Side note here, you know what a reflex is when you go to see your doctor and they do something like they have that little hammer and they tap just kind of underneath your knee and your leg kicks out. That's a true reflex because it takes no effort from you. You don't do anything. Your body just responds reflexively to a certain point. So when we're talking about swallowing, it's not exactly a reflex, as it is more like it is a response that our body has and a pattern of events or a cascade of events that occurs. And we're going to talk about those in just a moment so that you know what that means. But again, we don't really think about it. You don't have to think every time you swallow, do you? Oh, come on, muscles, get ready to swallow. Squeeze hard, squeeze a bit harder. No. So in that sense, it feels very reflexive because we don't have to think about it. In general, that time that it takes for you to swallow is about half a second. So from the point at which that food or liquid hits that point in the back of your mouth, that kind of oropharyngeal region, so like round the arches at the back of your mouth, from that point, it takes about a half a second for these maneuvers to occur that we'll talk about in just a moment. I think I'm actually going to skip penetration and aspiration and just come back to those in a minute. Okay, so let's talk about these things that occur when you swallow, and then I'm going to go back and talk about penetration and aspiration. So I talked about this series of movements or events that occur. So what really occurs? Well, this is what occurs. The posterior tongue base, meaning the back of your tongue, is going to push backwards and it will meet the back wall of your throat. And that's what, so if you think about this would be the back wall of your throat, here is your tongue. Your tongue is going to push that food back and it will meet the back wall of the throat. And this is going to start that pushing down of the food. So that's one thing that occurs. Another thing that occurs is we talked about that soft palate. Your soft palate is going to move up and back so that it seals off the nasal cavity. It's going to stop that food and liquid from coming out of your nose. A third thing that happens is the epiglottis is going to move. Now, your epiglottis is this flap of cartilage. Do you remember when we talked about the larynx, and we talked about the larynx when we talked about it for voice, and we had our cartilages, and we had that big leaf-shaped cartilage called the epiglottis. The epiglottis is very important in swallowing, because what you will see, if you take a little look at this picture right here, the epiglottis at rest kind of just sits up like this. But once you start to swallow, the epiglottis is going to move, and it actually kind of flaps down to cover your airway. That's to make sure that food and liquid don't go down your airway. So that's what we mean by epiglottic inversion. So at rest, the epiglottis is kind of sitting up, and then when we swallow, it automatically inverts to cover the airway. Your airway is down here, and it will protect your airway. Again, if you take a look at this little picture here, you can see the vocal cords. You can see that dark part down there, that's your airway. And here is the epiglottis. And you'll see here, as the person is starting to swallow, that epiglottis is going to flap down and cover this area right here. Again, that's what we mean by epiglottic inversion. It inverts or moves down to cover the airway. Another thing that happens, so we've got, again, these are all the things that are occurring during the actual swallow. We have what is called the laryngeal vestibule closure. So when you look at this picture over here on the left here, this is what we're talking about by the laryngeal vestibule. It's this area right above the vocal cords, this whole area right here. So as you swallow, this whole area basically just closes up. This is, again, it's to protect your airway, to make sure that you don't get, a piece of popcorn or, a big swig of Coke going down your airway right here. So when we have this laryngeal vestibule closure, what happens is that for some people, the vocal cords actually close. Doesn't happen for everyone, but probably for most of us. When you swallow, your vocal cords are open when you breathe, but when you swallow, for most people, they will momentarily close. That's a good thing, right? Because that stops, it's really protecting your airway nicely. Another thing that happens is that the larynx will actually move up in your throat. It moves up and forward. So we have this elevation and this anterior movement of the hyoid bone and the larynx. Meaning, again, as you swallow, so let's take a little opportunity maybe. If you put your fingers on your throat, and then if you have something to drink, you can drink it, or just swallow your saliva. Can you feel your larynx going up and down when you swallow? You should feel a little boink, boink. So that's what we're talking about with this elevation and anterior movement of the hyoid and the larynx. Every time you swallow, it goes up and forward. It should do. That's what it's supposed to do. It tucks up so that the saliva or the food and liquid can go where it is supposed to go. Back to this little top picture again. I know it's very weird when you look down your throat and you're like, okay, what is this and where does everything go? So when you swallow, your food and liquid is going to go down the back here. This area, this posterior area down there, that's your esophagus. That's going to lead down to your stomach. This right here is your airway, right? That's your trachea. So when you swallow, the vocal cords close, the epiglottis flaps down, and the food and liquid goes posteriorly down here. So that is your posterior pharyngeal wall. The other thing that happens is that we have this, what is called pharyngeal stripping wave. That means that the pharynx squeezes, your throat squeezes the food down. And the last part of this phase is at the top of your esophagus, you have what is called the esophageal sphincter. The fancy name for it, if you want to know, is the cricopharyngeus muscle. It is a muscle that at rest, if you see the picture on the right, at rest, it stays closed. But when you swallow, it opens up and it allows the food and liquid to go down, and then it closes up again. So here it is on the left, open, so that food and liquid can go down it. And on the right, closes back up after you swallow. Okay, that's a lot of information already. Let's take a little rest. And let's talk about a couple of things. Let's maybe go back. You know what I will do is I'll take a little moment to talk about a couple of other anatomical structures. And you know what? I don't know why I took it off your... I was trying to simplify the slides to make it less overwhelming, but I think what I may have done is also taken out a couple of terms maybe that we did need. So I'm going to take this moment, if I can, to just go over a couple of terms that are important, especially in this phase, this pharyngeal phase. And you'll see these terms that are in this top slide, top picture right here. So we have this area that is called the vallecula, which you can see right here, vallecula. And the vallecula is, it's like a little kind of trough that is between the base of the tongue and the epiglottis. So I'll show it to you from the side as well. Let's see. Okay, if we go back to this picture right here. So here is the tongue. This big pink muscle is the tongue. Here is the epiglottis from the side. And you see this little, that little area, that kind of that little trough right there? That is the vallecula. So it's just a space, it's an open space. Now, if any of you have ever taken a pill before, and you've taken this pill and you feel like, oh, that is stuck. Often it's like a big vitamin pill or something like that, that is massive and just doesn't go down. Frequently, where it is stuck is right there in the vallecula. You have to not panic, right? It's not blocking your airway, but you can feel it. And so typically what we have to do is we have to drink more liquid, or we may even have to eat something and swallow really hard to get it out of there. So if you can imagine, that's where it can get stuck, just because, look, it's a perfect pill-shaped little trough that you can get food and things stuck in. So that is the vallecula from the side right there. So you can see how it looks from the side. And then if we go back here from the top, it's this area right here. So it's between, this is the tongue right here, and that's the epiglottis. That's where you can get a pill stuck, or, you know, you've eaten a piece of toast and peanut butter that's just all sticky and you didn't chew it properly and it's stuck. It's often, it gets stuck in that area right there. So that's one important landmark to know. Another one is what is called the piriform sinuses. And you can see that word right here, piriform sinuses. Now we have these two channels at the back of the pharynx, and this is where your food goes when you swallow. So if you can imagine in the swallow, your vocal cords close, the epiglottis covers on top of your airway, and the food and liquid goes down these two little channels down here, which is called the piriform sinuses. And those piriform sinuses basically meet to create the esophagus. So your esophagus is back here, and those two sinuses lead to the esophagus. So let's take a moment to try and, oh, I nearly said to try and digest this, but and let me show you maybe what it looks like to help get those components in. So if we just review a little bit, the oral prep phase, if you're drinking liquid, there's no preparation needed. But if you are eating something solid, this is the phase where you chew it all up and you get it ready. The oral phase, all your food is ready to be swallowed. You've got these receptors in your mouth, especially towards the back of your mouth and in your tongue, and in the oropharynx, that tell your brain, oh, okay, food is here and ready to be swallowed. Your tongue then pushes that food up and back. Your lips make sure it doesn't fall out the front. Your cheeks make sure that it doesn't fall down the side, and you push that food back. Once it gets to this area at the back of your mouth, this oropharyngeal region, meaning the back portion of the mouth where it meets the throat, we start to kind of trigger this series of events that is the swallow. And that swallow takes just about half a second to be triggered. And what happens when we swallow? We have the tongue base pushing back and meeting the back wall of the throat. We have the soft palate closing off the nasal cavity. We have the epiglottis flapping down, vocal cords closing. The whole of the larynx moves up and forward. The food goes back down towards the esophagus and it gets squeezed down until it meets the esophagus. Now we'll take a look at that. Before we take a look at that, two other terms that are important to know. One of them is called penetration and one of them is aspiration. Now you may have heard of aspiration before. Aspiration, let's start there. Aspiration is where you have food or liquid that goes below the vocal folds into the airway. So you have all experienced aspiration before. And aspiration is where you eat and drink too quickly. You inhale some crumbs, you laugh and something goes down the wrong way and you cough and cough and cough. That's because you have had food or liquid that has actually gone down below the vocal cords, gone into your trachea. Now, hopefully you and I, you know, we're healthy, we cough and we cough it up. Whatever it was gets coughed up. So that is what aspiration is. And the reason why people tend to worry about aspiration is because if you are not very well, you can end up with aspiration pneumonia. If you have enough food and liquid that goes down into your lungs and you do not have a good immune system, maybe you're not very mobile, you can end up with pneumonia. And so for somebody who's already not well, that can be pretty significant. But for us, who are healthy and dare I say young, if we have food or liquid go down there, we're going to cough it up, we're going to be fine. Even if we had a bit of liquid that went down and we didn't cough it all the way back up, we're going to be fine because we're walking around, we're moving, we're healthy, our body can handle it. But if you're somebody who is very sick in bed, you're not going to handle it very well if something goes down the wrong way. So that's what we talk about when we say, oh, it went down the wrong way. We're talking about aspiration. Now, penetration is similar, meaning that food or liquid goes into that laryngeal vestibule and it can reach the vocal folds, but it does not go down between the vocal cords. So if I go back to this one, first of all, if you had food or liquid sitting in this area, remember this is the laryngeal vestibule. Think about it like a little room. It's a little room that sits above the vocal cords. If you have food or liquid that goes down that far, that is called penetration. If it goes down between the vocal cords, that's aspiration. So penetration is above the vocal cords, but it's in that area. It's in that laryngeal vestibule. Aspiration goes down between them. What that looks like when you look at it, this is an x-ray that we do to look at somebody's swallowing. You can see here we have penetration because we have material. All the dark stuff that you see is food or liquid. And here you can see the vocal cords are here. It is sitting on top of the vocal cords. Over here on the right, you can see, ooh, this is aspiration because this down here is the airway. And we can see here is this dark material that has gone between the vocal cords and has gone all the way down the airway. So that is aspiration. You can also see from the side here, here is that opening that I just told you about. That's that, it's the cricopharyngeal opening. It is that sphincter muscle. So your esophagus is down here. This is where we want food and liquid to go. And this is your trachea. This is where we do not want food and liquid to go. So you can kind of see, if we go back to right at the beginning where we said, really the process of swallowing is to get food to go from the mouth and down here to the esophagus and not go this way down the airway. Okay, so let me just see if I can share something with you. Okay, I'm just trying to share my iPad with you. Okay. Okay, so this is a little app that I have on my iPad that I find very helpful for looking at swallowing and explaining to people. So what we are going to do is we're just going to watch a swallow, and so that we can see what is happening. Now we can just orient ourselves to where things are. Here's your tongue. The dark gray parts are bone, so that is your jawbone. Those are your teeth. There's your upper, there's your hard palate, your alveolar ridge. There's your soft palate right there. So down here that's the pharynx. And then all the way down here, here's your esophagus. This is a side view. That's the epiglottis right there. Here's your hyoid bone. This is the larynx. All of these cartilages are the larynx. And right across here, here are your vocal cords. So we're going to see what happens as the person swallows, and we'll try and identify some of these parts of the swallow. Okay, so in comes the food. And so, oops, what we're looking at right here, in fact, this looks like liquid as opposed to food because we didn't see any chewing going on. So in comes this mouthful of liquid. So remember that movement that we said about the tongue? We're going to look for that wave-like motion of the tongue as the tongue pushes. You see how it's stuck right here on the alveolar ridge? It's going to push this backwards. This is our oral phase, posterior movement of the bolus. Keep an eye on the soft palate here, and let's see what happens to the soft palate. So what you saw there was the soft palate moved up, right, to make sure that nothing came out of the nose. We saw that posterior movement of the tongue meeting the back wall of the throat, the posterior pharyngeal wall, and you saw that bolus going down. Okay, so now let's go back again, and now let's watch another part. Okay, so this time, let's watch what's going on down here. Let's look for that epiglottis moving, and then let's look for that movement, that upward movement of the larynx. Oh, so look at that. Remember we said epiglottic inversion. There is that epiglottis that is flapping down to protect the airway. And you're looking for this upward movement as well. This forward and upward movement of the larynx. And then it goes back down. Okay, let's watch that one more time so that you can see the pieces. Okay, so let's watch for the epiglottis. Whoop, flapping down. Larynx moves upwards and forwards inside. The vocal cords are closing. And then we go back to resting position. All of that goes on every time you swallow. Who knew, right? It's really quite a complicated series of movements that occur. All right, let's go back to our slides. And then let's finish off with the esophageal phase. So the esophageal phase begins with the food and liquid entering the opening of the esophagus, and it ends when the bolus enters the stomach. So how long does that take? So remember we said that esophageal sphincter muscle opens as the food and liquid arrives. How long does it take then for that food or liquid to go all the way down to your stomach? Well, between 8 and 20 seconds. So that is going to depend again on the type of thing that you are eating and drinking. If you're drinking a glass of water, it's going to go down very quickly. If you are eating an In-N-Out burger, it's going to move more slowly because it's, you know, big and heavy and you have to squeeze it down. So we have something that is called peristalsis, and peristalsis is this squeezing movement of the esophagus that basically pushes the food down. Your food does move somewhat through gravity, but more than anything, it is this wave-like motions, this sequential squeezing of the esophagus that basically pushes that food all the way down until it reaches the stomach. Okay, so if I just briefly again go back to the, let's see, so we can see just that last part. Okay. Now let's watch out for this part right here. We want to watch for that last part being that beginning of the esophageal phase. So there was that opening of that sphincter muscle. And from here on down, this is the esophageal phase now. So as soon as we get that, this part right here, there's that muscle. Look, prior to that, it's closed. It's like a balloon. It's like a flat balloon before you blow into it. It just stays flat and closed. And it only opens up once the bolus arrives. There it opens up and then closes back up again. All right, now what we should probably do is watch a video or two. So let's watch a couple of videos. Let me just quickly go back. Hold on. Take a moment, take a little sip of something. Enjoy your swallowing. Show some gratitude. Okay. Feel free to ask a question if you have a question at this point. Sorry, I'm just trying to find my window. Here we go. Okay. All right. So we're going to just watch. Now, this is called a barium swallow study. So this is where we do a moving x-ray of somebody swallowing. And the food and liquid that somebody eats and drinks has barium in it, and barium is a substance that we can see on x-ray, and so barium looks dark. So when you see something dark on there, that's the barium. If you don't put barium into food, you cannot see it when somebody swallows. So the darker something is, the more dense it is. So you can see this is the skull right here, that's very dense. You can see the teeth are dark. And where you see something here that's very light, that's because it's a space. That's the pharynx right there, and it's an open space, so the x-ray goes right through it. So what we're looking at is, again, the darker something is, the more dense it is. So we are looking to see what happens when somebody swallows. Woo, look how quick that is. That's a normal swallow. Here's some liquid. This is what it looks like when you drink multiple sips from a cup. As quick as that. So this is real time. Now you can see that was thicker. That was a pudding, and the pudding travels more slowly. Oh, now here you can see something. This is something that needs chewing. So here's the oral prep phase right there. And what was interesting about that, let's just go back a second. So here's somebody who's got something solid that they're chewing. Chewing, 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 getting ready to swallow that. Oh, now look, when that bolus traveled back here, what you see is it actually plops into the molecular first, and then it gets swallowed. So this is quite normal for things to go in there and then just get swallowed. In it goes, and there's the swallow. Now we're going to look from the front. So what you may notice when we look from the front now is it's a little hard to see. You know, I said we have those two piriform sinuses. Food and liquid can go down both sides, and then it ends up meeting in the esophagus. So just know that we can look at it from the front as well. And then here it is going all the way down. Ooh, plop, 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 all the way down to the stomach. Woof. Okay. Let's watch one more. Okay, so we just watched one that was the x-ray. Let's watch it from the top down now. So if you were to look down, if we put a camera up your nose and had it dangling over your throat, this is what we would see when we look down. Don't know that we need that rousing music, do we? Okay, so the first thing that you will notice is, God, it all looks very swishy in there. And what you will see is that when somebody actually swallows, you get what is called a whiteout. You cannot see what happens. And that's because the camera is down, hanging over the back of the throat. So when the person swallows, you can't see anything. But okay, now, oh, there we go. Good shot. Vocal cords, epiglottis. So this is the back of the tongue. And what we want to see is the food and liquid go down here and here. These are the piriform sinuses. This is where we want it to go. It's getting chewed up, chewing, chewing, chewing. All that movement is, there's the swallow. There's the person breathing. And when we look down, we don't really see anything. Maybe a little bit of food there, a little bit of food there, not too bad. You can see the person's probably eating peaches, and you can see little bits of peaches every now and again. So this is what happens. This is what everything looks like while you're chewing. You're breathing, you're chewing. And then once that food is chewed up and ready, your tongue pushes it back. There's the swallow. And there's another swallow again. Oops. So what you can see, there's a little bit of peaches around here, but what we don't see, which is a good thing, we don't see any peaches around here. That's a good thing. We also see that it's been really well chewed up. So that's what it looks like as you are swallowing. All right. How's everybody doing? Very grateful to be chewing and swallowing. Tell you, it does. It makes you so grateful that you can eat whatever you like, swallow it without any difficulties. Okay. Let's go back to... All right. Now, what I'm actually going to leave you guys with is for your self-study for the rest of the week, you are going to read and learn a little bit about children. What kind of difficulties might children have? I want you to read up a little bit about what types of people can have difficulties. So we're going to talk about people with congenital developmental disorders, people with acquired disorders. If you have a change in your structure, for example, here are pictures of somebody with cancer. He's had his tongue removed. You can imagine, how do you eat with no tongue, no teeth? And that's because he had cancer in his mouth. It's going to change how you manage, right? Because you've got nothing to chew with, you've got nothing to push the food around. If we have time, I'll come back to that. Again, who else gets affected? You're going to read up a little bit and watch some videos of people who've got either strokes, brain injuries, degenerative diseases, people who have difficulty breathing. This is somebody who has a trach. If you have a trach, that's going to make it difficult for you to swallow because look, you've got a big tube in your throat. And I'd like you to read up a little bit about older people. You know, things change as we age. It doesn't necessarily mean there's a disorder or a problem, but it does change. If we have time, we'll come back to that. But what I do want to cover with you in the last little bit of time is to just talk a little bit about how we assess swallowing. How do we know what is going on? Well, if you really want to assess swallowing properly, we have to do what is called an instrumental assessment, meaning we have to be able to see the swallowing. And obviously, you can't see inside somebody's throat, right? You can only see inside somebody's throat if you do what is one of these two studies. The first one is called a video swallow study, a VSS. It is sometimes called a modified barium swallow study. It's the same thing, just a different name for it. And it is the first video that we saw that looks like an X-ray, right? If we want to see where food and liquid is going, if we want to see the problems with anatomy, the only way we can do that is by looking inside, and we can't do that with our eyes. So we need to be able to do it either through this X-ray, or we do it through what is called a fiber optic endoscopic evaluation of swallowing, which is called a FEES. And that is the one with the camera down the nose. So we're going to talk about those in just a moment. But what can we do just at the bedside? So, when I work in either the rehab hospital or I work in an outpatient setting, when somebody comes in to see me or I have an order to go and see somebody, what do I do when I don't have those available to me? Or what do I do before I send somebody for that? Well, the first thing that I want to do when I do a clinical swallow evaluation or a bedside swallow evaluation, so the doctor writes an order and says, can you go check out the swallowing? What am I going to do to check out this person's swallowing? Well, the first thing I'm going to do is to do a thorough medical history review. I want to look in that patient's chart and I want to see, did they have a stroke? Did they have a brain injury? Has this person got Parkinson's? Do they have cancer? I'm looking to really see what their medical background is. I also want to test their cranial nerves. Now, we're not going to go into this, but know that we can assess somebody's cranial nerves by asking them to do things. Can you smile? Can you pucker? Can you stick your tongue out? I can see if they've got some nerve damage. I want to maybe assess sensitivity. If I touch parts of their face, if I touch inside their mouth, can they sense it? Can they feel it? I can also check how long it takes them, perhaps, if I give somebody a cracker and I say, go ahead and chew that cracker. I can assess how long it takes them once they put that cracker in their mouth and they're chewing and they're chewing and they're chewing. That I can assess because I can see them chewing. I can check that after they have swallowed, I can ask them to open up their mouth and I can look for, did they clear everything out of their mouth? Is there anything in their mouth? Is there any, what we would say, oral residue? If I look in there and I see, oh my God, there's half the cracker, just stuck on their tongue or stuck down the side or stuck on the roof of their mouth. But what I cannot see is what happened to that cracker once it's gone, right? If I give you a cracker, I'm assessing your swallowing and I say, go ahead, eat that cracker and swallow it. Do I know where that cracker went? Nope. I mean, I know it's not in their mouth anymore, but I can't tell where it has gone. So in order to really be able to do a good assessment, we have to do one of these instrumental assessments. I need an instrument, I need an X-ray, I need a camera to show where it has gone. However, we have to start by just looking at the person and seeing what they are able to do as well. Now, I mentioned before, one of the big things that we worry about is pneumonia. And that if somebody aspirates, meaning they have that food or liquid go down between their vocal cords, we are more likely to see somebody who has got health issues have difficulties. COPD, which I'm hoping that you're going to read up about, is chronic obstructive pulmonary disease. That is when it's when somebody, like after somebody smokes for a long while, for example, and they have difficulties breathing. That's going to be a big problem. What about if I'm with somebody who cannot feed themselves? They're going to be at a bigger risk. What about somebody who is not able to walk? They're going to be at a bigger risk. So when we're looking at pneumonia, we're really more concerned in people who have more risk factors. Somebody who can't move around by themselves, somebody who can't feed themselves, somebody who's got breathing difficulties. I'm going to be much more worried about them, for example, than I am about you. If I gave you a drink of Coke and a cracker and you kind of coughed a little bit, I'm going to be less worried because I think, you're young, you can walk it off, your body will manage it. But that person who's lying in a bed, who cannot feed themselves, I'm going to be much more worried about them. So let's just talk a little bit about the X-rays, and I'd like to show you even just a couple. So it's a moving X-ray of chewing and swallowing. And it probably is what we would say the standard assessment. It's the best way for us to really assess how somebody is eating and drinking. So what is good about it? Well, it shows us the oral phase and the pharyngeal phase, right? I can see even the mouth. I can see the chewing because it's on an X-ray. I can ask the person, you know what? Can I have you just like put your chin down when you swallow? Can you turn your head to the side when you swallow? And I can see what happens if I ask them to do that. Another good thing about it is I can look down into their esophagus. We can follow that bolus, go all the way down. And we can see, does that bolus come all the way back up again? So those are the good things about doing this video swallow study. Paulina, I will answer your question in just a moment because yes, it's a good question. And then let's look at the cons. What's perhaps not so good about doing one of these video swallow studies? Well, the first thing is it's radiation exposure, right? It's like having an x-ray, and in an x-ray, we try and keep them brief, and now we're watching somebody swallow. So that can be a problem, is that there's radiation exposure. However, we try and limit that to less than 5 minutes, so we're not prolonging the exposure to radiation. So another negative about it is the study is short. We're only going to do a few food trials, a few liquid trials. Why? Because we're exposing them to radiation. I'm not going to say to somebody, let's watch you eat a whole meal and while we're taking this x-ray of you, because that would be too much exposure to radiation. Another con is that the patient needs to be transported to radiology. So we have to take that person who is in hospital, we have to take them down to the radiology suite to do that test. And maybe that person is hooked up to a bunch of machines. Maybe that person is really not very well and we don't want to transport them or move them. Okay, so let's watch maybe just one or two of these so that we can see what it looks like. And we'll look at what it looks like when somebody aspirates. Let's look at this one first. So here is somebody with Parkinson's. And what we can see is the person is doing lots and lots of chewing. And what I want you to watch for is, you can see all of this material that has, this is the barium in the probably in some kind of liquid or pudding. This person hasn't swallowed yet, and all of this material is just falling backwards. It's just trickling back before they're even ready. It's stuck in the vallecula here. Now remember, this is the airway at the front and the esophagus at the back. So, this is what we're worried about. Look at this. This is going down the wrong way. It should all be going down here, and here it comes anteriorly. So what you're seeing right there is coughing. That person is coughing, coughing, coughing. So this little bits of black that you see right here, that has been aspirated. That means that material has gone down between the vocal cords. He's coughing.
One more really, really hard swallow.
What you can also see is he has swallowed lots of times, and there is still lots of material that is just sitting everywhere, sitting in his throat. I'm going to stop it again here. All of this that you see, that's all aspirated material. So that's not good. It's going down into his trachea. That's going to go down into his lungs if he cannot cough it up. You can see all of this material. That's also aspirated material. So this is not a good swallow study for him.
Go ahead and swallow again really hard.
And she's telling him, swallow really hard. Oops. All right, let's look at one more. Let's look at a quick one. Oops. So right there, all of that liquid, you see that, probably 80% of it went down the right way, and probably a good 20% of it, that's a lot that has gone down the wrong way. So that is aspiration right there. Now, the thing that is not good about this either is you do not see this person coughing. Normally, if that was you, as soon as that started to go down the wrong way, you would see coughing, 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 but we don't see any coughing here. So side note, that is called silent aspiration. This is why if I give somebody something to eat and drink in my office and they don't cough, how do I know it's gone down the right way? I don't. They could be silently aspirating. It could be this person. I could give this person a drink of water and watch him drink and go, he looks fine. I don't hear any coughing. He must be okay. The reality is no. He's got a whole lot of material that has been aspirated, but he just didn't cough with it. I will get to your question, Paulina, really quickly. I want to see if I can, let's just go to, hang on. One more that I want to show you really quickly. This one. Okay, so now we're going to go to that other type of study, which is the one with the camera. Okay. Well, let's just watch this one. This is probably the scariest one to watch. Okay, so now we have a camera down the nose, and we're watching this person eat and swallow. Now, the first thing that I'd like to let you know is that we're watching somebody eat peaches, and often the food gets colored so that we can see it. So they've colored it kind of a blue color. And I would ask you to unmute yourself if you feel like you can answer the question. What is the first problem that you see with these peaches?
They don't look very chewed up to me.
That is exactly the first problem, is they are not chewed up, are they? These are whole chunks of peaches that somebody is swallowing without chewing them. Look at the size of that peach and look at the size of the airway. What would be your big concern here? That this person is going to inhale a piece of this peach and they're not going to be able to breathe, right? Because it's going to block their airway because it has not been chewed. So clearly we know there's a problem with chewing or managing the food in the mouth. That person is not being able to manage it. Oh no, look at this. We have more peaches coming backwards. So this is a big problem, right? Because now we see, look at that piece of peach that's stuck in the vallecula. We've got pieces of peach that are stuck in the piriform sinuses. So our big concern here would be that this person is going, oh, look at that. How frightening is that? It's sliding around. That piece of peach is, oh. And this is where you start to be very concerned if you are doing this study, is look at how scary that is, that you've got bits of peach just sitting all around the airway. So we don't actually see peach aspirated, thankfully. Let's go back and look at some aspiration here. So let's take a look. So we've got a bunch of blue liquid. So it's colored so that we can see it. There's the swallow. Someone's swallowing the liquid. Ooh, and now let's take a look. Okay, remember, this is our laryngeal vestibule. We should not have anything going in here. All the blue should be round here where it's supposed to be swallowed, but we've got all this blue material in the laryngeal vestibule. So already we know there's penetration. Now we want to look and see, does any of it go below the vocal cords? Look at it, it's all sitting on top of the vocal cords. So the person swallows again. And we're trying to see if we can see any of that go down between the vocal cords. Now, sometimes you can get a good shot down there and you can see. Sometimes it's a little bit harder. You can watch this again at home and maybe see a little bit better, but what you should see is right down there is blue liquid. Oh, you can see it trickling right between the vocal cords right there, yeah. So there we've got some aspiration of the liquid. Oh my God, it's the end of the class. Okay, let's briefly return to our slides again, just so that I can show you, just comment on one last thing. Okay, so the last thing that we did was we just took a quick look at this. That was how we put the camera up the nose. Last thing that I'll mention. The good thing about it, what are the pros of this? You can actually see the vocal cords, can't you? So that's kind of good. You can see the vocal cords. Because there's no radiation, I could have that camera down there for really as long as the person can stand it. I could have it down there for 20 minutes because there's no radiation. So I could actually have somebody eat a sandwich, a whole sandwich, and see what happens to that whole sandwich. That's very helpful if you want to see what happens over time. The machine is portable. That means I can take my swallowing machine, my fees machine, and I can go anywhere and test that patient, even in the ICU. What are some of the cons? Well, the first con is it goes inside the body, right? You've got to have a camera stuck up your nose, and some people are not going to like that. They're not going to want you to put something up there. Forgot my little bracket there. You can't view the mouth, so you're going to miss the oral phase. So if somebody is actually having difficulty chewing the food, you cannot see that, because remember, the camera is hanging over the back of the throat, so you cannot see what is going on in the mouth. One of the other cons to it is there's a whiteout. Remember, when the person swallows, it disappears and you can't actually see anything. So what that means is you can miss penetration because you cannot see it. That person may penetrate while they are swallowing, but we cannot see that because of that whiteout. I'm going to stop there, but you're going to watch those videos, and I'm going to answer Paulina's question, which was, let me get my chat box back. Have I had a patient that chokes while doing a clinical swallow evaluation? How do you deal with that? Yes, it's not nice at all. It is, it's scary for the patient. It's scary for you. But when you go and work in a hospital, number one, you have to have CPR training. So you have to know CPR. You have to know how to do the Heimlich maneuver on somebody, so that if they have a piece choke, they're choking on a piece of something, you can help them eject it. If you're in a hospital, like in an inpatient setting, obviously remember you have nurses and doctors around. It's actually worse in an outpatient setting where you do not have doctors and nurses around. It's you in an office doing it. If something looked really terrible, you would call 911. You would call a colleague to help you if that person really does start to choke. But the first thing you have to do is really look in the mouth and see if there's something in there that somebody can spit out. If they are really not able to swallow it and they are choking, you have to do a Heimlich on them. So I did have to do a Heimlich on one patient. That was not very nice. But he actually had his own caregiver with him. So between the two of us, we managed to get the piece of food up and out. But no, it's not very nice. So you have to just know that you have to be trained to manage that. I must let you go because you probably have another class to go to, but I am here. So I'm going to I'll put your weekly look. I'm going to adjust that, and I'm going to repost that for you and send you out an announcement so that you have some videos to watch. So you'll rewatch again a couple of those instrumental assessments so that you can see what it looks like. And then I will post for you homework number 9 so that you can answer that. And I may tweak homework number 9 a little bit based on what we did today. And I think that's about it for now. Please hang on if you have questions for me right now. Otherwise, I will post those things for you by the end of the day today. And then I'll be there in my office hours to see you. So cheers, everybody. Enjoy your swallowing. It will really make you appreciate it over the next week when you think about what is involved in every time you swallow. And I will see you next week if I don't see you in office hours. But thank you.